Hello, everyone, and welcome to our welcome to our next session. Exploring equity with CSB+SJU. Exploring equity with CSB+SJU students. My name is Bella Brinkman. I use she, her pronouns. I am a senior here at I am a senior here at CSB+SJU this year. I am a sociology major with a minor in global health, and I am serving as the Global Health Affairs President this year. In case you couldn't tell, I have a stutter, and over the course of last year, I was able to work on on-campus initiatives to both increase awareness on disability activism, as well as increase accessibility on campus. Over the past summer, through the summer leadership fellows program, I was able to intern at a FQHC located in Northern Colorado, serving mainly migrant farm workers. I am now going to turn it over to the rest of our panelists and let them introduce themselves.
Hi, my name is Sydney Richter. I'm a senior at St. Ben's, and my pronouns are she, her, hers. I currently am a political science major with now a global health minor, which is really exciting that we have the program now. This past summer, I worked for Representative Angie Craig in her district office in Burnsville, Minnesota, and then the past summer before that, I was in DC with Senator Amy Klobuchar's office, and that was both of the experiences. I worked specifically in health policy last summer, mostly with rural health and veteran health, and then the summer before with adoption and child rearing health. So those were kind of my experiences on campus. I am working for the McCarthy Center doing a podcast this year, actually. So, well, you should listen to it. It's called Let's Discuss. It's coming out soon.
Hi, everyone. My name is Andronique Denaya Roll. I use she, her pronouns. I am a senior theology pre-med major here at St. Ben St. John's. This summer, I was able to work through student Summer Leadership Fellows as a Fleshiker Center for Ethical Leadership Fellow. I worked with Diversity Council in the health equity space. I also continued my work with them currently. So Diversity Council is a nonprofit organization in Rochester that works to improve educational health and civic equity.
Yeah, thanks, guys. My name is Hannah Lisney. I use she, her pronouns. I'm a senior this year at St. Ben's and St. John's, and I double major in biology and peace studies with a focus on health equity. So this summer, through the Summer Leadership Fellows also, I interned at Northside Achievement Zone in North Minneapolis, and I was a part of their new health initiative that worked on providing doula and home visiting services to people in North Minneapolis.
Hi everyone, my name is Aronson Hernandez-Chaide, and I graduated from St. Ben's in 2019, and I am currently working for the Department of Human Services in their healthcare administration team, and I'm also going to the University of Minnesota. I'm in the Public Health Administration and Policy department, and it's my second year. It's my second and last year, and before that I worked for the Minnesota Department of Health. I've worked for the City of Minneapolis and Hennepin County's Public Health Department, so I've done a lot of levels of government here in Minnesota. I'm eager to share if anybody wants to hear more, and I use she, her pronouns. Thank you.
And good afternoon. This does work. Excellent. My name is Ethan Aronson. I work here at St. Ben's and St. John's. I work in the Experience and Professional Development Office, and I help create spaces essentially for students and employers and partners, alums to connect and do that career exploration as witnessed here. So I'm excited to moderate the panel and appreciate the privilege to be here today. So.
Thank you, everyone. So before we get us started today, I want to offer a chance just to get some of the jitters out and offer a space for reflection. So I want you all to think about a time when you had a problem or you had a situation in your life, and somebody had the best intentions, and we're trying to help you, and even though they were trying to help, they either made the situation worse or they made you feel disempowered in doing so. So think about a time, keep that keep that in your brain, and then share with the person next to you. So if we could just close up our conversations here. Yeah.
Hello, everyone. Can we please come back to the front? Thank you so much.
Thank you. Yeah. And I am just wondering if anybody would be willing to share with the large group what you or your partner talked about. Any brave volunteers? Well, that's okay.
Okay, I'll volunteer. I'm not shy. So what my sharing was is that I kind of did it, and I tried to relate it to healthcare. I had more than one occasion when something similar to this happened, but when one of my children were an infant, they were ill, and I kept taking them to the doctor and then taking them to the emergency room. And I was the first time mom, and they kept telling me, it's going to be fine, go home. It's a virus, go home. And all this. And the third time when I went to the hospital with my child having seizures, they immediately, grabbed me and said, oh my goodness, it would end up being a surgery, an immediate hospitalization, relatively severe. But in those times when I went in, I felt like I was just being an overreactive first mom. And I wish that they had valued my unprofessional, uneducated opinion that something was wrong with my child that didn't seem wrong. So,
thank you.
You're welcome.
Anybody else care to share? Go for it.
Let's say you get injured during a sport, and I guess maybe your mom or someone is trying to tell you that you shouldn't go back to the sport, trying to tell you find something else to do, trying to help, you guys feel like you say disempowered, all you want to do is go back to that sport, but they just tell you from the jump, oh yeah, that's it for you,
Mm-hmm. Yeah. Thank you, everyone. So as we talk about partnership as we talk about partnership equity, I think I can think of this really big conceptual really a big theoretical issue that doesn't impact us, but in reality, through all of the conversations in the room, we see that we all are impacted by it, and it does affect us all. So with that and keeping that in mind, I'm going to turn it over to Ethan here.
All right, well, wonderful. Yeah, we got some juices flowing in the conversation, which I'm glad. And I have a number of questions here that you all, I think, got ahead of time too, and want to make it kind of open forum. So I'm not going to call on anyone in particular, but would love everybody's input and insights. So we'll just start off with what experiences have you had on the topic of partnership equity and how it relates to health equity, both in your personal life and professional experiences? And in addition to that, has there been any key moment where you've seen how equitable partnerships create health equity in a community? So if anybody would like to.
I can start out because I have two topics in mind. Thank you for your question. So currently in my Master's of Public Health, oh my gosh, administration over here, where I'm doing at the U of M, I'm in a class called Global Health and Local Context, and that class specifically has 4 different professors of different varying backgrounds in charge of field trips. We get to go around Minnesota and get to see Native American populations in Minnesota in their local context. So like we'll take a walk with them, we'll hear from them from their holistic needs. And that's one of the varied field trips. We'll get to go to Fort Snelling as well. We went to a farm in St. Paul that's not very well known, and we got to hear about the sustainability and climate concerns that they personally have from people around there that are more on what people say like on the poorer side, but just they're struggling. And so people were able to come and declare like what their needs are, how their farm works, and how they get their food and how the farm helps. And I think when people who specifically are going through experiences are able to explain themselves, share their stories, and share their needs specifically to people who are curious or wondering, is empowering. And I think that's essential to change or to create those changes that I think now we are looking for, and I think people have always wanted to see. And then another topic at the University of Minnesota, my other topic is at the Department of Human Services. In my current position, I was able to witness and see a new kind of initiative and program called, oh my goodness, I'm blanking out now, Conversations That Matter to You. And these conversations were meant to bring people from different varying backgrounds. So we had different people from Hmong background in Minnesota speak about their needs to the Department of Human Services, who do a variety of things for the state of Minnesota, from helping homelessness, from cleaning, like making sure water sources are clean and regularly verified, and then just a variety of things, women's health, family health. And so we had that. We had an LGBTQ group speak as well. We're going to have Indigenous and Native American speakers soon, and then we're having ableism and disability as a bigger topic now, and we're having speakers from a variety of job sets in Minnesota come and speak. So I think when people are invited from a variety of backgrounds as well to speak in like larger sets, that's also critical to making sure leadership understands who really, like what people's needs are that normally don't have a voice at the table as we usually hear. So yeah, those were 2 things that I had in mind and I wanted to share.
I can go next. So Diversity Council usually works with a lot of big organizations in Rochester, such as Olmsted Public Health, Olmsted Medical Center, and Mayo Clinic. And so these organizations work together and they form like task forces or work groups. So in Olmsted County, there is a community needs assessment. So this assessment goes out to residents, and these work groups, they try to make sure that it also reaches the rural areas of Olmsted County and not just focus on like the city area of Rochester. And so what the community health needs assessment does is that people fill out their survey and they recognize the top priorities as it relates to health. So this past survey that just happened in the summer, the #1 health priority was mental health. And so what these organizations do is they not only see what the community needs, but they put their minds together, they put their forces together in order to create solutions as to what these health problems are in the community. And so that was an example that came off the top of my head. Also, Diversity Council also worked with different smaller organizations in the Olmsted County area on something titled Project Healings. So this project was based on COVID vaccine hesitancy. And so Diversity Council, along with partnering organization, worked to have like mobile vaccine clinics. They provided like transportation for people who wouldn't have been able to like access the vaccine to come to these clinics and these different events. And so the partnership aspect of all of this is what was able to like help these projects come to fruition.
Terrific.
I have less of a public health like organization background and more policy and government. So I think I've seen a little bit more of maybe the negative side of these not having public health partnerships in any form. One thing that comes to mind is I did have a good experience in Senator Klobuchar's office when I was working with adoption and foster care agencies. We, at least in that area, they were very, very good at working with lobbying groups and community health organizations and consultants who work within the foster care system. And that was where all of the information was coming from, like all of the legislative ideas, everything completely came from those community members. The problem being, usually the people who we were speaking with were white cis men. So it's not actually the people who are being affected by these policies. So I think a huge problem, at least in the policy area, is looking at who has a voice and who's getting through to elected officials, because that's really where all of our policies came from. So that was definitely something that was good and bad, I guess. And then I got to study abroad in Ireland last semester, and I took a class about public health, specifically looking at health systems in France, Ireland, and the US. And I think that they were very much more focused on these equitable partnerships, and that made the biggest difference in their health outcomes. Even though we spend all this insane amount of money on our health care, like the places that aren't spending all this money but have these partnerships are the places that have better outcomes. So that was definitely a eye opener for me.
Yeah, Sydney, I'm actually going to go off of that, sorry, but I came into college and I wanted to be a doctor. I was pre-med, I knew what I wanted to do, and then the more I took classes that looked at our health system, the less I wanted to be a doctor, the less it seemed fitting. And it is sad, a little bit, just thinking about the negative aspects of our health system. But a lot of our health programs right now are set up where we don't acknowledge or appreciate the patient's perspective, and our audience member even said her personal story. We don't look at our family's experiences. We just kind of look at that biological only. It's got to be medicine and only medicine. We never look at the people as whole. And it really goes back to just like not inviting everybody to the table. And so having open conversations with everybody, I think, is super important. We also, right now, there's a few of us, me and Sydney specifically, are in a history class. I see some other students in this class and our professors in the back. So quick shout out to you guys, but we're talking right now about the colonial past and how our colonial past specifically has affected health in America and global health as a whole. I think we can talk about equity, health equity here and in partnership, but if we don't talk about that a little bit and acknowledge that we have really made some big mistakes and have impacts that are still affecting people today, we can't really have a discussion about how we can make equitable changes and equitable partnership without looking back at that. So yeah.
Thank you, guys. So a fun little tidbit that I learned last year is that America spends the most money on public health of like the in like the 20 developed nations, but we have the worst health outcomes. So it really shows that it's not that we're not putting the financial resources into it, is that we're not creating a system to use the money in a way that's effective and actually like improving the health of like other people. In terms of, in terms of like this question, I think like the disability justice movement has taught me so much about, I feel like I'm learning every day about accessibility needs that I've never even like thought about. Like I feel like every day I hear something, I'm like, oh my gosh, that has never even crossed my mind. I know I saw on TikTok a couple weeks ago, of all places, there was a video of like Kamala Harris, and she was doing her introduction, whatever, and she was describing like, I'm a person like sitting in a chair and I'm wearing this colored suit, and everyone was making fun of her, being like, why do you have to describe what you're wearing, like we can see you? And then I saw later that's for people who are hard of seeing / are like blind. They want to be able, if they're listening to a like video, they want to know what the video is. And that was so like, that's something, that was a concept that I've never thought of I've never thought of before, but it makes so much sense that if you're wanting to watch a video but you're hard of seeing or blind, you want to know what you're quote unquote looking at. So I just feel like I'm continuously learning more, and that goes back to the conversation of having everybody at like the table, and that the people who are actually being affected having a voice to say what they need, because then otherwise how are the decision makers and our like leaders supposed to make effective change if they don't know what the community needs or wants?
Well, I knew I was going to be learning stuff today, but wow. Really, this is, it's just enlightening, and I really appreciate all your insights too, because and for me personally, it brings back, I've done a lot of nonprofit work in different communities in different places around the country, and it just brings back a lot of interactions and experiences I've had too. And obviously this is something that's been going on, and I think you're on the cutting edge and being right there in the present moment, experiencing some of these things and putting forth your strengths into fixing that puzzle, right? So connected to some of the later comments that were made in the last question there, what are some current issues, and I know some were mentioned, what are some current issues you see related to partnership equity and the overall theme of health equity that you've seen in your own work, and how have the organizations you've worked with strived to overcome some of those challenges?
I can go. So one of the issues in partnership equity is, let's say a bigger organization works with a smaller organization, and so the bigger organization puts in more resources than the smaller organization. So this is seen a lot because smaller organizations tend to partner with the bigger organizations to help them with their initiative. And so one way that like diversity councils wants to like overcome this challenge of like unequal sharing between organizations is, of course, creating like a collaboration agreement. So collaboration agreements, they outline everything. This is what like my organization is willing to put in or has the capacity to put in. And so these are great because it keeps it like helps with autonomy for like the smaller organizations, and it also sorts of like makes sure like the organizations hold themselves accountable for what they were supposed to do or what they were supposed to put into the project or the initiative.
When I was in Representative Craig's office, I did a lot of casework specifically with Social Security, Medicare, and Medicaid issues. So people would come if they, got their Medicare unrightfully taken away from them, or there's just a technical issue, whatever it may be. And we would work with that organization because nobody can ever contact the federal government and try to fix it. But the problem was, how many people in the room even know you can contact a local representative about these issues? Like, nobody knows that. It's just not a thing. I only knew about it because I worked for one. So all of the people who actually have the problem don't know where to go with it, and then they try to get on the phone with Social Security, and they're on the phone for 12 hours and don't actually get an answer, and then they just, give up, because what can you do? There's no, I will say Angie Craig was putting in a lot of work to work with organizations and get the word out there for these issues, but broadly across the United States, elected officials just aren't putting in the effort to work with communities and organizations and public health initiatives that actually would be working with people who are having these issues. And so often they are, people who are either differently or disabled, people who are low income, just vulnerable communities in general, LGBTQ+, like whatever it may be, it's all of these minority people who aren't getting access to the things that they need, and we're not working hard enough to access those communities. And it's just problematic, because then the only people we end up helping are like Grandpa Joe over there, who is fine without it, but obviously like he needs it, but like it's not really doing that much for him. And that's all that we're really helping out with. So I think that was one area that there needs to be a lot of change, and nobody's really trying very hard to fix it right now.
And I want to add more to what you said, because I finally was able to dive into coding and data analyzation in my master's studies. And I and a couple of other students from underrepresented groups have made the realization that there isn't a lot of data out there regarding healthcare utilization or access for very specific groups, such as Native Americans, so Native Americans, or American Indians is another term. And I wanted to look at this group, or the Hispanic and Latino or Latinx groups. Use of a qualified interpreter was one way that I wanted to look into, like immigrants versus citizens or non-citizens, and the data isn't out there for the Latinx community, so I couldn't end up doing that research question. I'm answering it for a project, and it's upsetting because we have these questions, or we think the data's out there, and the data isn't out there because certain people maybe don't even think about doing the research. Or like years ago, many, many years ago, people aren't thinking about these things as important topics or important research questions. And many of the researchers historically have been white individuals, so if it's not catering necessarily to what their needs are or what they're looking for, possibly the research isn't gonna be necessarily sought for. And then something else that I wanted to add in regards to health equity and data is a lot of policy and legislation look for data to create those policies. They want to see the data, so then they'll be like, yes, okay, we get it. We see that there's actual numbers out there. We can give money to that. And so for one of my policy classes, if we couldn't find the data, and there was a lot of questions friends and other people had regarding really, really good topics, couldn't find the data. Thus, they couldn't answer their research questions. And so thus, in the end, we can't be figuring out these really hard topics or hard problems because the data is non-existent. So we need people who are from underrepresented groups to get the resources to become researchers or scientific doctors, so they themselves can do their own research in the communities, and that trust is then there. Is something else I wanted to add to that.
Yeah, and I'll circle back to Andronique's comment just about that power dynamic. If you're partnering up with two organizations and they might be of different size, they have different resources, even they'll be knowledgeable about different things, that creates a lot of challenges. And specifically in the work I did this summer, I worked for Northside Achievement Zone, and they had a lot of money. They just did. They were a nonprofit, but they were really good at gathering funds and doing all of these fundraisers and events. They had a lot of money to spend on this program, but we were partnering with organizations that were a lot smaller, and they really wanted to make sure that they could cover, paying their employees and paying all the people that are working with them, and making sure that this is a sustainable project. So right now, the project I worked on, it's just a one-year pilot program, and so at the end of the year, it might be done, which is clearly not equitable at all if it does just end right there. But on the other hand, if we can find a way to make sure that the funding is consistent, maybe you make the program actually long-standing, And that's just a challenge I don't know the answers to, honestly. I don't know. I don't know how you fix that. And, you know, people are fear funding programs without any data. So we're going to do this pilot program, and hopefully we'll get the data that shows that this program was a success and that, you know, we should be funding more money into it. But if it's not, you know, we don't know where you go with that. So I just think that power dynamic is super important to look at. Just in partner equity, you need to make sure that both partners, you know, are in a safe space where they can be doing work that's good, but you're also not just going in and doing work for a year if you can avoid it.
Something that was cool at the the FQHC I was at, I forgot why I forgot the acronym there, which I realized I didn't I didn't explain what the FQHC is. It's like a federally qualified healthcare center, and it is funded from the federally funded from the government, and it provides free / like a sliding scale primary healthcare like services. So anybody can come in, regardless of regardless of immigration status also, which I think is super important, and they can get healthcare based on a level that matches their income, which I think is super important. And there's about 1,400 across the U.S., so there's 4 in Minnesota. And I think it's a super awesome way that, in my opinion, healthcare should be set up. But one of the federal regulations in having a FQHC is that 51% of the board has to be 51% of the board has to be patients, which I think is super crucial, because other people on the board are like the CEO or like the COO or the chief medical the chief medical officer, in which these are people who have had the opportunity to go to higher education. They've had a lot more opportunity. So then to have 51% of the board be like the members of the members of the community that are being served, I think that's super important, and I think it led to better policies being made for like the clinic.
Oh, there we go. Yeah. And you'd think that concept would have been something that should have been established a long time ago, right? I mean, for the people, by the people, right? And yeah, so that actually, yeah, some great comments that lead kind of into collaboration agreements being one of the recommendations for best practices, you know, when forming partnerships and such equitable partnerships. But do you have, like, what other kind of recommendations for establishing equitable partnerships have you come across, you know, including maybe having a diverse team, establishing a common language amongst the partners, and relying on community feedback being another one too? So in your experience and knowledge, how have you seen equitable partnerships being made and formed, and what are some of those best practices in your experiences?
I would say, like, an example of best practice is meeting people where they're at. So if an organization, I've used organization a lot. If a partner is like, they are like it's an area that they are confident in, so they're the experts in this certain area. And so anything with the initiative or the project that has to do with a certain area, they're the experts. So the other partner wouldn't try to say, well, this is the way I would do it, or XYZ, because not everything applies in like different contexts. So letting the experts work on what they are experts in is another way to ensure equitable partnerships.
would totally agree with that. That's actually something that we did too at the organization I worked with this summer. Another big thing that we did was hearing from the community, actually, and from the people we were trying to serve, and then also the people we were going to be working with. So we worked to implement doula services, and so that requires, having moms and hearing from moms, potential moms, and but also the doulas. So you want to make sure that you're creating a program where the moms and the birthing individuals feel like their needs are being met and they're being understood also, but you're not misusing the doulas, or you're not, making the workload even harder than it already is for doulas. I guess I should say for doulas, they're somewhat like a midwife, but they would a lot of times explain it that they work from the waist up. So they're there advocating for the mom in the hospital. They're doing visits throughout and talking to the moms on the phone and responding to texts about concerns and questions. So they're really just the mom's biggest advocate. And so when the family's there, when the family is there at the hospital, the doula is most concerned with what the mom needs. Does the mom want what's happening right now at the hospital? Are the doctors respecting her wishes? And then the family can just be there to, be excited and support her. But that was just, there's a fine line between you want to offer both sides, a fair and equitable system that'll work and it'll be longstanding without stepping on any toes. And so we conducted surveys. So we sent out surveys to doulas and we asked a ton of questions about, how many visits are you willing to do? And what do you think is a fair pay? And are there anything you're worried about for, being involved in this program? But we also talked to moms, and I really think it goes back to like having everybody at the table. You have to talk to everybody because you cannot just assume when you probably are, so far off. So I think that's just one thing that's just super important.
And then a recent experience that I wanted to add to this conversation is working at the Department of Human Services government agency, for the state of Minnesota. They have a lot of administrations, and they have a specific division that works in community engagement. And me being in the healthcare administration department administration for the summer, I was extended. But for the summer, I really wanted to do community engagement work within healthcare administration. And one of my coworkers told me community engagement is specifically only for the division or team that does that, not for us. And I thought that was confusing because I think every administration should be doing community engagement in some way if they really want to help and inform Minnesota, as we have a lot of people in Minnesota. So speaking about that with my supervisor was also in agreement that our administration as healthcare administration needs community engagement involvement, and we were able to start the conversations, build up a website, build best practices. And I think this will initiate other administrations to also have their own community engagement steps to getting people within local and rural Minnesota, so rural Twin Cities, I should say, Twin Cities, that's local, and then rural Minnesota, involved and engaged. And so I just think if anybody's getting involved with government or businesses, making sure your teams, administrations, or divisions aren't siloed, making sure that they're communicating, and that community engagement isn't just for one solo team, that community engagement is a topic of conversation for many teams to get involved with, and a variety of perspectives to get involved with as well.
Okay, I think also when a community member comes up and gives you an idea, it could be anything. I know, thinking like CSB+SJU, like I want an accessible room. Let's just use that as an example, right? You immediately are going to think of why you can't do it, and you're going to try to think of everything why you don't want to do it, all the policies, all the procedures, all the issues that could cause, whatever. And I really think it's about challenging those no's and thinking about what is what is the benefit that this can give somebody, and how can we make this work, instead of immediately thinking of your first thing, which is saying no, that's going to be too no, because that's going to be too hard. Because I think that's where a lot of these really great ideas get stopped, is because it's going to be a cost, it's going to cost too much. It's going to be too much work. We don't have the whatever, and really challenging those first ideas that come into your head.
Yeah, I think kind of building off of what has been already said, especially in governmental offices, it's not just who you're speaking to about these issues. I mean, that's already a problem. We don't speak to the right people, but it's who's in the offices, because that's, who are people willing to speak to about these issues, and it can be really difficult for underrepresented groups to speak with, Amy Klobuchar is a great senator, but who's going to go up to Amy Klobuchar and be like, here's my problem, especially when her staffers are all white. I think some offices are better than others, but we have such a huge problem in that region, especially on the Hill, of everybody is a white, straight person. Typically, the representatives are older men, and everybody else is like a 25-year-old man. So I think there is a lot of room for improvement there on just hiring people who are going to be responsive and maybe easier to speak with than a scary man who thinks he's incredible and a politician. I think that's, again, a huge problem with, even though there is community partnerships there, it's not really being equitable at all.
All excellent points. Definitely, I'm taking all these notes, and I'm not being quizzed or tested on this, but it's all very, I think it's all very pertinent, very relevant to each of our day-to-day, experiences, and I think, this is just terrific. So as we kind of wind it down into, I got a final question or pair there maybe, but so health disparities, they don't have a single cause, right? Many health disparities come from social and systemic causes such as transportation, language barriers, food insecurity, and so many more. How have your community organizations adopted to take on this multi-sectional issue? So what are the challenges and benefits of taking a multi-sectional approach to these issues?
I think the obvious answer right away is just that there's no single cause of any disease. It's just there's so many different aspects that affect people's health, and it affects the way that people look at health, and it affects the way our doctors think of health, and the way we think of treatment. And so if you don't have this, multi-sectional approach to solving everything, can people get to their appointments? Can they afford their appointments? Can they afford the medicine after? Do they have a pharmacy nearby? I mean, that's not even covering a little bit of what we should be looking at. So I think that's just what comes to my mind, at least right away.
I think the clinic that I worked at over the summer really did a good job at this. So it was the clinic, which was just health services. And then they also partnered with a local behavioral health clinic, in which had behavioral health specialist in the office, which was also at a affordable cost. We also had vision, we also had dental, and then we also had the county's social workers also on site to do case a management. So we really try to create a one-stop shop for any social service that you might need, because they recognize that you might be having a physical issue, but if you have behavioral health issues, if you have food insecurity, if you need case management, all of that works all of that works to affect your health. We did Uber and Lyft rides to get patients in. We didn't use telehealth, which to me at first seemed why wouldn't you use telehealth? To me, that's a solution to fix health inequity. But then what was later explained is that a lot of patients didn't have Wi-Fi, they didn't have phones, or their phones could get turned off. And so we try to incentivize coming in person. So I think we really use the multi-sectional approach in trying to see health as like a full scale and not just your primary healthcare services.
Building off of that, specifically with like broadband and internet and everything, so often policies, especially on the federal level, are so niche and like trying to attack this one specific issue, but it's like the majority of the people you're trying to affect don't even have access to healthcare. They don't have access to broadband. So why are we having all these millions of telehealth organization funding things when people who actually need the telehealth can't access the internet? It's like, that doesn't make any sense. So we're just throwing money at the wrong issues, and not necessarily the wrong issues, but the wrong root cause, and kind of just trying to duct tape over the problem. So I think, having that sort of approach, looking at the root cause rather than just trying to fix things, and then also, so often we, I lost my train of thought. I'll go with that for now. I might come back.
And then I just wanted to add, I think that multi-level intersectional approach will always be really relevant. We can't understand things just being all full quantitative and only numbers or all only qualitative with words and what people are saying. We need both. And going back to something I explained in the past is back to qualified interpreters. Data's out there for like a small town or maybe even a city, but like for a whole state to have the data on like qualified interpreter use for a underrepresented population, it's not out there. For the whole country, it's not out there. And a lot of legislation or policies are made with a wider range of people. Some people don't think 20 people, 50 people in a research data is legitimate. So they'll need more people, and using those multi-levels, intersectional approaches with open minds and with people that come from these underrepresented groups partaking in the research and analysis is gonna allow more people and more trust to happen. And so then you have the data that you want in the end.
So health equity is really, really broad. So looking at social determinants of health, the way that you're able to know what these determinants are is to go into the community. And so what Diversity Council does is a co-design process of creating initiatives and resources for the community. So basically what a co-design process is, a facilitator from like the community, it can be like a community leader. They usually come into like the process, so they sit at the table and they are compensated for it. So usually in the past, it's been that like these organizations, they reach out to like a certain group of people and they say, well, they pick a leader. They're like, okay, you're the leader. What's wrong? Tell me what's wrong and we'll fix it. But the problem with that is that these organizations are like the structure, they create like these programs, but they don't really work because it's not really what the people need. And so with the co-design process is that these are people in the community, they sit at the table, they create the resources, they create the initiatives and stuff like that. So what Diversity Council does is that it offers these resources in like the health equity space to help people to be able to obtain certain services. So like I said before, Diversity Council works closely along with Olmsted Public Health, Olmsted Medical Center, and Mayo Clinic. And so sometimes they have like transportation to like these certain events or like to like the clinics itself. And so that helps like community members be able to like trust sort of like the initiatives and the processes that are being presented. And so even though they're faced with these disparities, they could find like some sort of solace in knowing that someone who was also facing the same disparities as them created the initiative, created the process.
I want to add one more thing too. One last thing I wanted to mention is our terminology is constantly changing, and to be updated in like terminology is also going to be critical. In my department, in my work, I was kind of called out by, I'll be honest, I was called out by saying, a nice old man help me, old now to say that to a person is deemed unacceptable or rude. And one of my supervisors kindly called me out and said they don't want anyone else calling me out. And so I appreciated that from her and was embarrassed and realized, oh my goodness, I can see how this is harmful. And I'm trying to stop saying guys, like, hey guys, and trying to use the terms friends that I normally use, because if saying hey guys will just cater to one certain gender. So there's just all these things. It's good to keep an open mind. It's good to stay updated on terminology and keep an open heart with people. You know, people are not trying to be out there to get you. They're just trying to help the world, honestly. So yeah, just wanted to add that.
Yeah, some great examples. Yeah, just really opened my eyes. It sounds like the Diversity Council in particular, Andronique, they're kind of, it sounds like they've pulled in a number of these best practices in terms of like looking at the experts doing being experts in their work, but bringing the community to the table, building those collaborative agreements, and agreeing on the resources being used. I mean, all of that kind of coming together sounds like that's building an effect. It sounds like, from your perspective anyways, an effective, an equal partnership of sorts, which is terrific. Yeah, again, I've just learned so much, and I think if we're open to it, we could turn it over to the audience at this point for some questions for our panelists, and it could span the range maybe. We do.
So Kaya's going to help with the mic. She'll bring it to whoever wants it, or if you're over on that side, it's more convenient to go up to that mic. You can.
All right. This is a really interesting panel. Thanks for all of your perspectives. Sorry, I can't see all 5 of you at once. I'm curious, as someone who works in public health, I often find myself drawing from areas of study or things I learned in college or earlier that I just was like, wait, why is that coming into play? Like, it's a very interdisciplinary field, right? So I'm actually curious for you guys, are there things for you all, thank you for reminding us of inclusive language. I'm curious for you all, are there sort of unexpected like nuggets of experience or of study that you've had to bring to the fore in your public health work or in your, in your studies so far that kind of surprised you, or that might surprise the group here as like, oh yeah, that's maybe not as kind of traditionally interpreted as public health, but you're bringing it to what you do.
Yeah, I guess one thing that comes to, I have 2 things that come to mind. One just being education and how much it affects, how medicine plays out and how we all live and access health care. One thing being just like most of us in this room, I'll be honest, I am not, I'm gonna guess most of us are not super health literate. So when you get, your medical files and you're reading it and you know some of it, you get the gist of it, you know what the doctor told you, but you don't know most of it. And we have so many cases where, my mom's in the room, but she's taking my grandma to the doctor all the time because my grandma doesn't know what the doctors are saying. She doesn't understand what's happening. And it's not something that's, specific to a community who's not health literate. Most of us aren't. Most of us don't know common terminology that the doctors are using. We don't understand it even if we do know what it means. So that's one thing that I found surprising, and I figured that out in a health communications course. And then the other one, Ellen, you showed me this, but just how much culture affects disease and medicine. And so we just read an article. I learned about this today, so I'm still learning. But type 2 diabetes and how we look at that as, something that is technically curable, and the way we live our lives now is causing a lot of people to have these preventable diseases, and we have so much research and science, and we're just kind of slapping a Band-Aid on the problem. We're never looking at the root causes of it because our culture is now in a way that, we don't eat the healthiest most of the time. We like to go out and eat with our friends at a restaurant that it might not be very good for you. We don't, you know, yeah, so I guess that's just the two things, just how much culture affects disease and medicine, and then how important education is in accessing healthcare. Thanks for reading your homework. I always read my homework.
This might seem like no brainer, but to me, I was just like so overwhelmed over the summer about how much like government regulation goes into healthcare. Like I had a crash course in like Medicaid and like Medicare and 340B, which is affordable prescriptions, and like I like left the summer being like, oh my gosh, like I think it seems so common sense, right? Like of course the government has a say in healthcare, but like after the summer I was like, everything is so interwoven, and the relationships between the government and the healthcare systems that most of the time feel very combative instead of collaborative, which is funny to me because like both the government and the healthcare systems want healthier people. So to me, it's like, don't you want to be working together? But at least in the space that I was in, it felt like they were fighting with each other. And that's something I'm definitely more interested in now, maybe pursuing, is more of that policy and how can we have government and healthcare systems work together to create healthier people instead of like feeling like they're fighting with each other to do so.
So Bella, I want to let you know that right now at the Department of Human Services, that is exactly what administrators, managers are speaking about, is how can physicians and both the Department of Human Services administrators and health equity directors have a more collaborative approach to helping Minnesota out in Medicaid and Medicare. And the one doctor I specifically work alongside, his name is Dr. Nathan Chamalo, and he's done great research for underrepresented groups, specifically Black African Americans in Minnesota. He says the social determinants of health, using the word determinants, to him is a deficit language. He says, I use social drivers of health. So that opened up my mind to think, okay, that is where I'm gonna try to gear my language at, because last year I was reading and writing a lot about social determinants of health, and still to this day we'll be reading a lot about the social determinants of health, unless a lot of people agree that's wrong and we're gonna change the language up. So again, just being easy on yourself, terminology might change.
I can go next. So I work in health promotion on campus, Stop at Buzz and Dream Team. And so I joined because I just love creating like graphics and I'm really passionate about health. And so I was like, this is gonna be a fun job. It's only 5 to 6 hours. I get to make up my own hours. And so I was kind of surprised, but like not really surprised, to find out how like health promotion sorts of like is a branch of preventative care. And so preventative care is like really important when it comes to public health. And so simply like seeing a graphic or like a poster or something like that can actually change someone's like attitude as it relates to a specific health issue. Let's say like, for example, vaping. So there has been like a campaign by Olmsted Public Health just like focusing in like high schools and like the Olmsted area on like vaping. And so a lot of the like graphics or posters, they're like sort of like on the funny-ish side. And so like seeing how that like helps with preventative care, therefore also helping with like overall public health, I feel like that was pretty nice for me to see, yeah.
All right, I want to follow up on Aronson's comment on kind of the deficit approach, because public health is a lot geared to people who are deficient in some way. And so we've been talking about partnership between organizations, but ultimately you're dealing with individuals as well. And so in a lot of healthcare, you got, one person who's whole, and oftentimes the primary caregiver presents that way, and the other person's broken. It could be a broken limb or depression or whatnot. But within public health, you have the thing like, okay, you got pregnant as a teen, you did drugs, you vape, you eat too much, all these kind of things. And I'm wondering, but the other person's whole, they don't do those things, And I'm wondering if you saw any models where you're able to take advantage of the insights of people who aren't that different, or that break down kind of that I'm okay, you're not, but I'm here to help you kind of thing, that maybe gets in the way. Because I've heard, for instance, that healthcare for homeless sounds like a great plan, but they end up being underutilized, the funds, because it's like, the healthcare sounds nice, but I don't really want to come out as homeless. You know what I mean? So I'll pass on that. So I'm just wondering, in terms of the whole kind of deficiency model, and have you seen anything that works there, and partnering with people kind of where they're at to have success? Thank you.
Yes, so for one of my job parts that my supervisor wanted me to do is figure out if there were any models out there for this, specifically health equities, making sure all people on all levels are involved. And I did the research, and I did find a couple that I think are going to be specifically in particular important in use of government and use of with physicians and health systems, hospitals, clinics to align and work together. And I saved them in my OneNote, and then they're going on our website soon in DHS for Healthcare Administration. But it's really hard sometimes to find all these little websites that our government has. Sometimes it's really hard, sometimes it's really old, and I was really happy I could help beef up a couple of our old websites, because I just wanted to get involved with that. So I do have that saved. I could send that over to you if you want to see those 3 models, but I can't off my head name them. I remember one of them is from the Minnesota Department of Health, though. It's like a triad model. It uses 3 specific big parts. And then one of them I remember, I think, is from a university, I think on the East Coast. So that's all I can say right now.
Something that the clinic that I worked at really tried to do is that it was a clinic for everyone, not just quote unquote the poor people or whatever. They were trying to be they were we're gonna have a nice facility. The facility's gonna feel good to everyone. We're gonna keep it up. We're gonna have the top-notch doctors there. They didn't want it to be seen in the the community is only certain types of people go there because it's whatever. And I really appreciated that, it being we want this to be a reputable, good clinic where everybody would want to go to, not just a certain sect, and trying to reduce that stigma, if you will, in that way.
I think going off of what Aronson said earlier, destigmatizing, you just have to be really, really inclusive. So that can be with language, with practices, and just certain things like that. So even if something is geared towards a specific group of people, just making it known this event is open to everyone. For example, Diversity Council worked with different organizations. I'm just gonna call them out, AMA or HACER. And so HACER usually, their events or their programming is usually geared towards Latinx people, but the events are open up to everyone. And so even though it's geared to this specific group, it's still that aspect of inclusivity that surrounds the certain event or initiative.
I think just shortly, this all kind of comes back to the idea of who's at the table and who gets a voice. And, if we're going to continue to kind of, we're talking about in the class we're in right now, the colonized versus the colonizers, and why it's so important to not just, have these white people who think they know what they're doing. And so often people in our healthcare systems are, the typical cisgender white person, that's not going to be necessarily speaking to communities that are really needing services that we're trying to provide and destigmatize. So last year with Ellen's class, me and Bella actually did a project where we looked at the effects of COVID and vaccination and everything on the St. Cloud Somali community. And we spoke with some Somali refugees who work in the healthcare system, and the effect that they had on their community was insurmountable compared to the white physicians that worked with their community. It's like the language barrier, everything. So I think who's at the table and who are we educating to be doctors and things like that are just so important.
And follow up and just ask Hannah a specific one. If you remember, I was very impressed by the parenting program when I talked to your site supervisor there, because that's another one that I think, if somebody sends me to a parenting program, then I think, I'm a bad parent, and I'm going to learn from good parents. And so back to Bella's initial sort of thing on when has somebody tried to help you, but you come out kind of reminded each time you go that it's like, I'm a deficient parent. I hope this class works so I don't hurt my kids, or don't raise them in a way that's healthy and whatnot. So could you tell them a little bit about NAS's?
Yeah, so NAS, I guess, focuses not truly on health. So I picked this organization just because I interviewed and I just loved the people I worked with. So although I'm interested in health, and thank God they had a health program that they were starting, but they do a lot. So one of the things that they offer is what we would call NAS coaches and NAS coaching. So parents get to attend. It's once a week for about an hour. They get to meet up with other parents and just talk to what we would call a coach. But really, it's just somebody who also has been a parent before, and they talk about all the developmental milestones that they should be looking out for, any concerns they might have. They can talk just with a group of other parents. So I guess, the terminology, if somebody was like, oh, you should go to this parenting class, I would, I'm sure a lot of people would be offended at first, but I actually took the class just because I wanted to see what it was about. And the whole idea of it is like empowering the parents to feel like they're already the best parent their kid has. They have everything they need to be a great parent. Maybe it's just a little bit of, maybe they're struggling with how do you discipline, and what way of discipline works for you, because it's not the same for everybody, and it's not going to work for everybody. So we're given a space to have those discussions with other parents. It wasn't necessarily a class where you take notes and you listen to the instructor. It wasn't really like that. It was just a lot of complaints and a lot of concerns and honest conversations and people laughing. And they would start every class with playing a song and just having the moms and the dads and whoever was attending the class and their kids dance. So I took it on Zoom, so the kids are just dancing and the parents having fun. So it was just, I guess, a community gathering, less of a course, if that makes sense.
Right. Hi, I'm Lisa Adams. I'm coming from Dartmouth College and Dartmouth Medical School in New Hampshire, and I'll be speaking later tonight if you haven't had enough and are still craving more conversation about global health equity and partnerships. So your stories are incredible. The work you're doing is so impressive. It is really, really commendable. And so many great things that you've already talked about around true community engagement, about how language matters. Those soft, gentle call-outs, do become priceless. I know it can be hard to take them, but when that was a real gift, right, from your supervisor. So I just feel like following up on a little bit about what Bella was saying in terms of your realization that healthcare is has so many federal and other regulations that constrict maybe doing everything that you want to do. I'm wondering if you have thought about where has the pushback come from? What have been the challenges? Where is, the next layer of work to be done to make all the great things that you're doing and the great programs that you're working with, to make them universally accepted, to make them, our business as usual approach and our common practice.
I thought about funding right away. One thing for sure is funding public health streams, organizations. I'm thinking about the Women, Infants, and Children department in Hennepin County that I was able to work for, and they have a certain limited funding stream, but their funding stream, they made really good use of it with making sure they had programs, brochures, farmers markets, extra formula for these mothers and families that would come, and that as a nutritionist, I would be able to help. And I saw a lot of the families felt more fully filled because they had a wide range of brochures or information or help from not just food or not just children education, but like all children education, food, healthcare, dental work, and they felt fulfilled because you were hitting all these different areas. I remember I still keep in contact with my supervisors and the WIC program, and one of them was very nervous of WIC getting blocked streamed funding during COVID, and everybody was just crossing their fingers that they would continue to get formula, they would continue to get certain resources like farmers markets, so people could go get fresh fruits and vegetables that normally do not. So funding is always, I think, going to be surrounding public health. During COVID, we saw how lack of funding, also lack of initiation and good leadership led us to also suffer with COVID, and public health, it was supposed to, take the reins on that, and unfortunately, a lot of us suffered with that. But besides funding, money doesn't always just solve everything. Also, like making sure the people have a say, because money won't always solve everything.
This is my own personal, maybe a little bit unacademic opinion, but I feel as though our society has devalued public health because it's not snazzy, it's not cool. I got to play with a $3 million surgical robot over the summer. That's snazzy and cool. People want to invest in that. That's fun. A new drug. That's cool. That's snazzy. People want to fund that. But creating better schools and reducing gun violence and having people eat healthier, that's not snazzy. People don't want to invest in it. People don't want to fund that because it's not fancy. It's not innovative. So I feel like we need to help voters and our politicians understand the importance of public health and preventative health care, because overall, if we're going to talk about taxpayer dollars, if less people end up in the ER who are uninsured because they're not having health emergencies, overall that's going to cost tax dollars, or that's going to cost taxpayers less dollars, because not as many people are having health emergencies and winding up needing emergency surgery. So we need to reprioritize that preventative health care is where our focus should be, and not reactive health care.
Yeah, I agree. And building off that, the problem is, I think it needs to be a culture change, because politicians aren't going to do something unless it's going to give them good, publicity. They're not going to do something unless it's going to get them votes, let's be honest. So if people don't want to see that, then the politicians don't care if it's good or not. They're really educated people. They probably know, yeah, we should invest in preventative care, but if their constituents don't care, why would they do it? So I think it has to be a culture shift, but yeah.
Okay, I wanted to sort of go off those 2 points because preventative care is just so important. And I think one of the issues that we as a society have is that people don't really have access to preventative care. And so people, they would say, I only go to the doctor when I need to. I don't want to go unnecessarily. I don't want to have to pay this big bill. My insurance won't cover it. So changing the culture around that would be significantly important to having a shift towards more preventative measures in our healthcare system.
Hi, thank you so much for everything you've shared. This has been a wonderful panel, and I'm sure everyone is learning so much. I just had a question about like homelessness and unhoused individuals. So I just started working at Alina Health on the health equity team, and I'm working specifically within the urban Native community in the Twin Cities. And so we have done, we've done a bit of work so far just with talking to community members and things like that, but a main root cause or issue that is very apparent in the Native community, as well as I'm sure many other communities, is unhoused individuals not even being able to think about accessing healthcare because that's the last thing on their mind. And so I was just wondering, in your experiences, in your different roles, if you have any perspectives on how your organizations possibly support unhoused individuals, or just how your organizations have navigated that.
Do you know what Portico Health is? Have you guys looked into that? Okay, so Portico Health is an organization that basically helps people access what they would call affordable health care. I don't think it's very affordable still. It's like $139 a month is the cheapest rate you can get. I'm sure some parents in here think that's really affordable, but I don't, especially, if you don't have a home, if you don't have a place to shower so you can go to work, or you don't have a phone to get a call back from an interview. All of those things, if you don't have that, then it's not a very affordable rate, but Portico is an option. It's a great organization if it works, I guess, for that situation.
I thought of trauma, how much trauma happens within homelessness communities, and Hennepin County has a team specifically to de-escalate trauma that people go, so people aren't stigmatized if they're yelling or screaming or crying, that's just a reaction to the traumas people without a home have gone through. So de-escalation programs or trainings that can help people inform on the different types of traumas that exist, how a trauma shows up, and how people can be patient or ready when people appear with their traumas in a way that maybe isn't normalized for us to witness. There was one more thing I wanted to share, but I don't know. I think I kind of lost it. Sorry. Maybe I'll think about it.
So I don't know if this is just a Colorado program, but at least it was in Colorado. But we utilize that through Medicaid. If you're a Medicaid or Medicare participant, you can get free rides to your appointments. And you just have to call them and set up, say, I need a ride to and from. And that was a really good way to patients who either couldn't drive or don't have access to a car. To get to their appointments. I thought that was really cool and something I didn't even know that Medicaid, Medicare offered, so.
I remembered it. So I think historically, a lot of times, people were calling 911 when they wanted to help someone on the streets. Now that's not so much the case anymore. I think it's 988. Is that the new mental health number to call? I think just making sure we're advocating for the new number, sharing with others what the new number is for and how it's really going to help mental health awareness, as I think our mental health should continuously be talked about. Everyone struggles with something at one point in time. So yeah, that's the one thing that I finally remembered.
Politicians don't care about homeless people. So, is this public? Is this video going anywhere? Hopefully it doesn't bite me. But yeah, so they don't care about homeless people or houseless people because they're not voters, unless they're veterans. We're not going to do anything for them. Obviously, there are some programs within Medicare and Medicaid, but that's just for, people want the government to help homeless people, but they don't really care that much. So, yeah. Take that as you will, but that's my take.
I think that's a part of the job for civic equity. And so in ensuring that everyone has a home, or everyone at least has access to somewhere that they could lay their head, would be really important in helping civic equity. So what certain programs, these people would need advocates. So people who are like really dedicated to their work with them. And so they need representatives to represent them like at the table. And so a lot of community organizations have like task forces that specialize in these areas, and they like see what the homeless population or the homeless community needs, and they try to bring those resources to them, because of course they don't have like a way to get them themselves.
Right. I guess I will we'll pause on that note, and yeah, thank you all. No, thank you all very much. Really enlightening, and to reiterate, yeah, you're just all doing amazing work. Everybody chiming in with questions and insights and taking notes and taking those back to your communities as well. I think we all have a part to do in this, obviously. So thank you again for all of your sharing today, and appreciate you all being here as well.